Let's begin with a clinical case of trichomoniasis. A 26-year-old woman presents to a genito-urinary clinic with a chief complaint of profuse yellow, foamy vaginal discharge that has a foul odor. The symptoms started 2 days ago and are accompanied by vulvar irritation and itching. She also reports pain during vaginal intercourse, known as dyspareunia. Her sexual history reveals multiple partners, which is an important risk factor. On physical examination, the physician notes homogeneous vaginal discharge and vulvar erythema. A particularly characteristic finding is observed on speculum examination, a diffuse macular erythematous lesion of the cervix, classically described as strawberry cervix. She also has lower abdominal tenderness. This clinical picture profuse foamy discharge, foul odor, vulvar symptoms and strawberry cervix is highly suggestive of trichomoniasis. Trichomonas vaginalis is a protozoan parasite and the causative agent of trichomoniasis, one of the most common non-viral sexually transmitted infections worldwide. Unlike other protozoa we've studied, T. vaginalis exists only as a trophozoite. There is no cystic stage. This is important because it means the organism is fragile outside the human body, and transmission requires direct contact. The trophozoite is the infective stage. Morphologically, it's unicellular and pear-shaped. It has 4 anterior flagella and an undulating membrane that make it actively motile. This motility is a key diagnostic feature. The infection is associated with an increase in vaginal pH above the normal acidic range, typically rising to 5 to 6. In women, the organism inhabits the vagina and can cause significant symptoms. In men, it inhabits the urethra and is rarely symptomatic, though it can occasionally cause mild urethritis. This asymptomatic carriage in men makes them important reservoirs for transmission. The primary mode of transmission is during sexual intercourse, making it a true sexually transmitted infection. The trophozoite of T. vaginalis enters the genitourinary tract during sexual intercourse. The organism preferentially attaches to squamous epithelium lining the vagina and cervix. Direct contact between the parasite and epithelial cells leads to destruction of these cells. While the exact mechanism isn't completely understood, surface glycoproteins on the parasite appear to mediate this cytotoxic effect. The parasite literally damages and kills the epithelial cells it contacts. This cellular damage triggers the development of a neutrophilic inflammatory reaction. The body's immune system responds by sending white blood cells to the area. This inflammation, combined with the parasite's activity, causes petechial hemorrhages, tiny pinpoint areas of bleeding in the mucosa. These petechiae create the characteristic strawberry cervix appearance we saw in our case. All of these processes, epithelial damage, inflammation, and hemorrhage, lead to vaginitis, the most common clinical manifestation. This explains our patient's symptoms: discharge from inflammation and cell death, itching from irritation, and the strawberry appearance from petechial hemorrhages. Now let's examine a second case with a different presentation of candidiasis. A 25-year-old woman presents to the clinic complaining of bothersome vulvar itching and thick, whitish vaginal discharge that has lasted several days. Importantly, she reports having experienced such episodes in the past but did not seek medical attention. This recurrence pattern is significant. She also admits to having multiple sexual partners, though we'll see that unlike trichomoniasis, candidiasis isn't primarily a sexually transmitted infection. On physical examination, the physician observes vulvar erythema and notes thick whitish discharge. This clinical picture, thick white discharge, often described as cottage cheese-like, intense itching, and recurrent episodes, is classic for vulvovaginal candidiasis. The difference from our trichomoniasis case is striking. No foul odor, white rather than yellow-green discharge, and the thick rather than foamy consistency. These distinguishing features are crucial for clinical diagnosis. Candida albicans is a gram-positive yeast cells, unicellular, oval in shape. Candida reproduces by budding, a form of asexual reproduction where a small daughter cell grows from the parent cell. You'll often see budding yeasts in clinical specimens, a parent cell with one or more smaller buds attached. A crucial diagnostic feature is the presence of pseudohyphae in clinical specimens. When Candida transitions from the yeast form to the hyphal form, it forms elongated structures. True hyphae have parallel walls and no constrictions at septa, while pseudohyphae show constrictions at the points where cells join. In vaginal discharge, seeing both yeast cells and pseudohyphae on microscopy is diagnostic for candidiasis. This morphological transformation from yeast to hyphal forms is not just diagnostic, it's also associated with the organism's ability to cause disease. This diagram illustrates the pathogenic mechanisms of Candida albicans infection. Candida normally lives as a harmless commensal in the vaginal environment in many women. However, certain predisposing factors can trigger disease. Antibiotic use that disrupts normal bacterial flora, pregnancy with elevated estrogen levels, diabetes mellitus with elevated glucose, providing nutrients for fungal growth, immunosuppression from HIV or medications, and use of oral contraceptives. The critical step is the morphological transformation from yeast to hyphal forms. This switch is strongly associated with enhanced pathogenic potential. The yeast form is relatively harmless, but the hyphal form is invasive. This transformation is triggered by environmental factors like pH changes, temperature, and nutrient availability. With this morphologic change comes the appearance of virulence factors. Adherence to epithelial cells occurs with the aid of surface manoproteins. These act like molecular Velcro, allowing the fungus to stick tightly to vaginal epithelium. Once attached, the hyphae secrete proteinases and phospholipases that digest epithelial cells, facilitating tissue invasion. These enzymes break down proteins and lipids in cell membranes and extracellular matrix. Finally, this invasion induces an inflammatory response with recruitment of neutrophils and other immune cells, leading to the clinical symptoms: itching, burning, discharge, and erythema. Understanding this pathogenic cascade helps explain why treating predisposing factors, not just the infection itself, is important for preventing recurrence in our patient who had multiple previous episodes. Now let's discuss how we diagnose these sexually transmitted infections in the laboratory. Different clinical manifestations require different specimen types, and choosing the correct specimen is crucial for accurate diagnosis. For vaginal discharge causing vaginitis, which we see in both Trichomonas vaginalis and Candida albicans infections, we collect vaginal discharge or use a vaginal swab. The specimen should be collected from the posterior vaginal fornix, or from areas of obvious discharge. For urethral discharge indicating urethritis in males, which can occur with Trichomonas or bacterial STIs, we collect urethral discharge or use a urethral swab. This is particularly relevant for trichomonasis in men. For genital ulcers caused by organisms like human herpes virus types 1 and 2, we need different specimens: ulcer swabs taken from the base of the ulcer, or vesicle fluid aspirated from intact vesicles. The specimen type must match the clinical presentation. Proper specimen collection is essential. Specimens should be transported quickly to the laboratory and processed promptly, especially for Trichomonas, where trophozoites lose motility rapidly after collection. Understanding which specimen to collect for which clinical presentation is a fundamental skill in diagnosing STIs. This slide shows various microscopy techniques used for diagnosing these sexually transmitted infections. Let's examine each method. The wet mount is the classic technique for Trichomonas vaginalis. A drop of vaginal discharge is placed on a slide with saline, covered with a cover slip, and examined immediately under the microscope. The key finding is motile trophozoites. You'll see the characteristic pear-shaped organisms with their jerky, tumbling motility. This motility is what makes the diagnosis. Seeing the organisms moving is diagnostic. The wet mount must be examined quickly within 10 to 20 minutes, as trophozoites lose motility after the specimen cools. For Candida albicans, gram staining is used. The specimen is heat-fixed, stained with gram stain, and examined under oil immersion. You'll see purple staining gram-positive yeast cells, often with buds attached, and the characteristic pseudohyphae elongated structures with constrictions. For genital ulcers caused by herpes virus, immunofluorescence can detect viral antigens in infected cells from ulcer scrapings. Fluorescent antibodies bind to viral proteins, making infected cells glow when viewed under a fluorescence microscope. Giemsa stain can also be used for Trichomonas, showing the morphological details more clearly than wet mount, though you lose the advantage of seeing motility. Each technique has specific advantages for particular organisms. PCR is highly sensitive techniques can identify organisms even when present in very small numbers. For our topic, NAAT can detect Trichomonas vaginalis DNA from vaginal swabs or urine samples. For genital ulcers, it can identify human herpes virus types 1 and 2, distinguishing between the two types. It's also invaluable for detecting human papillomavirus or HPV, which cannot be cultured. The advantages of NAAT are significant. First, its rapid results are available in 2 to 4 hours compared to days for culture. Second, it's highly specific, reducing false positives. Third, it's especially useful for organisms that cannot be cultured, like HPV, or that are difficult to culture. Fourth, it can detect organisms even after treatment has begun, when culture might be negative. Prevention of sexually transmitted infections requires both specific and non-specific measures. Let's start with specific prevention vaccines. For HPV infection, we have highly effective recombinant vaccines. The quadrivalent HPV the 11th of June 16/18 vaccine protects against 4 HPV types, types 6 and 11 that cause genital warts, and types 16 and 18 that cause cervical cancer. The bivalent HPV 16/18 vaccine protects against the cancer-causing types. These vaccines are recommended for teenage girls, ideally at age 13 before sexual debut, administered as 3 doses by injection over 6 months. The vaccines are highly effective when given before HPV exposure. For hepatitis B infection, which can be sexually transmitted, we have an effective vaccine that's part of routine childhood immunization. Non-specific prevention measures are equally important. Behavioral and lifestyle changes include reducing the number of sexual partners and choosing partners carefully. The practice of safe sex using barrier methods, particularly condoms, significantly reduces STI transmission. Early diagnosis and treatment of cases and their sexual partners is crucial. Treating only one partner leads to reinfection, the so-called ping-pong effect.